Hello, and thank you for joining us for the Wisconsin Parkinson Association's educational video series. I'm Jeremy Otte, Director of Outreach and Education for the Wisconsin Parkinson Association. WPA provides hope, community, support, and resources for people with Parkinson's and their loved ones. Today, we are talking with Erica Vitek from Aurora Sinai Medical Center in Milwaukee. Erica is an occupational therapist who specializes in movement disorders like Parkinson's disease and is a certified pelvic rehabilitation practitioner. Welcome, Erica. Thank you for joining us today.
Thanks for having me.
No problem. So can you touch on what exactly a certified pelvic rehabilitation practitioner is?
Sure. Yes, Jeremy. So basically, one of my specialty areas besides Parkinson's exercise is pelvic rehabilitation. And so pelvic rehabilitation consists of bladder issues, bowel issues, or sexual health issues that might come up for anyone. But in particular, I have a special interest in helping individuals with Parkinson's disease that have those difficulties in their day-to-day. And so the certifications that I have two of them. You mentioned pelvic rehabilitation practitioner certification is through a company called Herman & Wallace. I'm a faculty member with Herman & Wallace. They provide pelvic rehabilitation education, and I have written a course for them. I'm the author along with another physical therapist, and our course is called Neuro Pelvic Floor Rehab. And so our basis for our course is multiple sclerosis, spinal cord injury, and Parkinson's disease, and how do PTs and OTs help to rehabilitate those individuals with pelvic health kind of complaints or difficulties day to day. And then my second certification, along with my pelvic rehabilitation certification, is in biofeedback. So it is a board certification in biofeedback for pelvic muscle dysfunction. And biofeedback is one of the tools of many that I utilize in my clinic to help with relearning or learning pelvic exercises to strengthen or to relax, depending on what the individual needs, to help with bladder, bowel, and sexual health issues.
Can you touch on a little bit how some of these issues may affect a person with Parkinson's disease?
Absolutely. So bladder issues and bowel issues are definitely extremely common. So I'll start with those two first. So let's think about the bladder. So with the bladder, what happens is in many people with Parkinson's, not everyone, they think, somewhere between 60 to 80% of individuals may experience this throughout the course of their disease, in that you have more urgency or need to go to the bathroom, or more frequency, so going more often. And really common is also really small volumes of urine when going to the bathroom. And so that kind of all fits together in that you're having all this urgency, but not a lot is coming out of the bladder, so it doesn't seem to kind of match up. So the reason for that, the hypothesized reason, and it's been looked at much in the literature, is that when we have less dopamine, there is less what we say the word inhibition or calming of the bladder. So as the bladder is filling up, dopamine at normal levels would kind of calm that sensation. You wouldn't even notice it when there's a small amount in there when the dopamine levels in the brain are normal. But when we have less dopamine in the brain, our bladder is not calmed as easy. So we have this more of the sensory awareness of the bladder filling up even to very small amounts, and it causes us to have an urge to go to the bathroom, and then we go more often, or the urgency is a lot stronger. Sometimes it's harder to hold, and therefore incontinence can result. And so with pelvic rehabilitation, we can actually curb all of those things and help to improve day-to-day life, because that significantly affects individuals' ability to go out of the house, even maybe to sleep through the night or to get things done day to day. The bowel issues that are most common are actually constipation. Constipation is thought to be one of those early symptoms in many cases that comes way before maybe the disease is even diagnosed. And so some studies even show that up to 20 years prior to diagnosis, constipation has been present. And so 80% or so of individuals that have Parkinson's disease do experience constipation. And so the issue with that is there's some slower emptying of the stomach typically. There's slower movement throughout the colon. And then there's also some difficulty in actually the strength of the evacuation ability of the body. With the lack of dopamine, all of those things are caused. And so all this slowness happens, just like our movement is slower when someone has Parkinson's, then the gut also kind of follows that similar pattern with slowness of that whole system in getting the bowels to mobilize. The third thing is sexual health. And so there can be a lot of different things related to that area. Some of the main things would be motor problems with movement, right? So being able to have relations with your partner in regards to your movement or positioning abilities, your fine motor coordination, those kind of things, but also differences in how you feel about yourself, and maybe anxiety or depression, or maybe drooling, or some other the things that come along with Parkinson's disease that can affect your ability just to feel attractive or feel like you're attractive to somebody else. And also, individuals sometimes have to split sleeping arrangements because of sleeping difficulties. And so now they're not sleeping in the same bed. Or their partner is now their care partner instead of just the individual that they've married or that they're with. And so there's a lot of different things that can be affected there. Just as a side note as well, dopamine in regards to sexual health is kind of a driver of reward and pleasure. And so when there's less dopamine, that tends to be kind of dampened, and it's not, that system isn't driven as much as it is in someone with a normal level of dopamine.
So when I think of pelvic floor, I think of urination. You've touched on a whole lot of other things, bowel issues, sexual health. Can you maybe touch on, is this a more common in males and females, common for both? What do you kind of see in your practice when you're working with people on these issues?
Mm-hmm. Yeah, so the bladder issue tends to be really kind of across the board, male and female, but I would say probably more female, only because I feel like the females actually bring that up a little bit more to their doctor. Males may not. I don't know if it's necessarily underreported in males or not, but it does seem to happen fairly equally, at least in people with Parkinson's, around about the same. General population, though, as I just mentioned, probably women do complain of these problems a little bit more. But the most common in Parkinson's, like I mentioned before, is that urgency, frequency, maybe a slower stream when going to the bathroom, and getting up at night a lot to go to the bathroom.
So I always hear people, I don't drink a lot of water during the day. I try and cut down on my fluids, so I don't go at night. But you're kind of talking about that you're going to go at night no matter what, just because of the way the muscles are affected. So can you maybe touch on that a little bit?
Sure, absolutely. So in the pelvic rehab kind of setting, what I do is I really get like a good idea of what kind of fluids are taken in all day long, what you eat, what the habits are. I may have you measure how much you go to the bathroom, or kind of diary a little bit for me so I can really analyze that. And really what we want to look at initially is reducing dietary irritants. So taking in things that are irritating to the bladder, such as caffeine, carbonation, acidic type things like tomato or grapefruit or orange. So we kind of look overall at the profile of what does the intake look like, and we try to manage that first. And like you mentioned, some people try to limit their fluid intake because they're going to the bathroom all the time. But that can actually perpetuate the issue in that bladder infections become more common, which then causes the symptoms actually of frequency and urgency. And dehydration, terrible for people with Parkinson's, especially because low blood pressure, so what we would typically refer to as orthostatic hypotension in Parkinson's disease, is really common. And so lack of water intake because of the bladder problem is definitely not a good idea. And so more water intake during the wake hours, earlier in the day, Still doing that earlier in the day will definitely help the nighttime problem to not have a lot of fluids in the evening time. So we can still at least get that in during the day. And so what I do in the clinic is really help people shape that to make it work for them, because everyone is a little bit different. So what I'm talking about are some very general things that I may consider suggesting, but we definitely shape it to the individual to make it work for them.
And when you say fluids, I know we've talked before, coffee, diet sodas, things like that. Maybe do the opposite of what we want with water or maybe certain juices.
Mhm, mhm. Yeah, so water and more clear, kind of like apple juice, cranberry juice, white grape juice, those kind of things can be a little more tolerable. Water is definitely the best thing to do. The recommendations vary, but one of the most common things you see right now is drink half your body weight in ounces of water per day. But that sometimes doesn't work for everybody, especially if you're going from drinking like almost none to doing that. You probably won't like me very much. So I wouldn't go from drinking none to that, but it's kind of a goal to shoot for approximately. They used to say, 8 glasses a day, and that's an okay way to think about it too. 6 to 8 glasses a day. You do have to consider other things you're eating that might have fluid in it, like soups or cereal or things like that, veggies, fruits, and things. So that's just a general recommendation. And again, you don't want to go from having none to a ton, because then it's going to actually cause some of the symptoms we talked about. Got to get your bladder kind of used to filling up again and retraining it.
Moderation, just like anything else, right?
Yes.
So we talked about some of the issues, lack of dopamine, maybe not being able to empty the bowels or the bladder fully, or feeling like you have to go when you don't. What are some of the tips or exercises maybe you would talk to somebody about trying to help maybe alleviate some of those issues?
Yeah, so there can actually be two problems that we're dealing with, and that's the challenge of just giving a general, like, this is what you should do kind of overreaching statement. So what I want you to think about is the two things that basically the pelvic floor muscle does is the base of the pelvis. I'm talking about that muscle, sometimes referred to as Kegel or Kegel muscle, as the gentleman that developed these exercises in the 60s. And so basically, that muscle can either be too tight or too weak, or it could be actually be also in a normal position as well. But tendency for that muscle to either be too tight or too weak in individuals that have the complaints that we've been talking about. And so if it's too weak, I work on strengthening that muscle and giving an individualized exercise program to what that person can tolerate and handle, because everybody's muscle is a little bit different. And if you don't individualize it, it can become frustrating to do the exercise because it may not go very well for you, or you may not sense that you're doing it correctly. If the muscle is too tight, that's also a different problem, and we actually have to work on relaxation. And surprisingly enough, weak muscles and tight muscles both can cause urinary incontinence. So it seems like it wouldn't be that way, but it actually sometimes almost more likely a tight muscle causes urinary incontinence for a variety of reasons, that you're just not able to activate the muscle the way we want you to be able to activate it. When you kind of relearn how to use the muscle, all of these symptoms can be alleviated. And it's pretty amazing that the conservative approach like this can actually help with those things. So the other thing to just think about in regards to this muscle is that when the muscle is tightened and we tighten it, that encourages storage. So it encourages the bladder and the bowel to hold on to the urine and the stool. When the muscle is relaxed, it encourages the emptying or the release and gives permission for the release of that. And so working with the nervous system and all of the functions of the muscle and trying to just iron out all the signals can be really beneficial and helpful doing the pelvic rehab. Just as another note on that, Jeremy, is that a conservative approach of pelvic rehab is really important, especially for people with Parkinson's, because the medications used to treat these problems are not the best for someone with Parkinson's disease. Sometimes they're used, but not extremely widely, because they can also cause other problems, such as more constipation, problems, cognitive issues, dry mouth, and some of the things that we don't want to happen when utilizing those. So using conservative measures of exercise can really be helpful in alleviating the need for more medication side effects, and all of those things.
I think that's great to hear. I think some people just assume throw medication at it, and once in a while the medication makes the actual symptoms worse, or other symptoms worse. I think it's good for people to be aware of when discussing this with their practitioner. I'm going to ask you a real quick question. You mentioned incontinence. Can you touch on maybe the clinical definition of incontinence? Because I've heard it a couple different ways, and I think people get confused once in a while as to what it is and what it isn't. So if you can maybe give the clinical definition of what it is, I think that might help some people out.
Sure. Yeah, absolutely. There's a lot of different kinds actually. So it makes sense that you may have heard different things. So stress incontinence or stress urinary incontinence is when there's leakage from the bladder with some sort of pressure on the abdomen. So like a cough, a sneeze, a laugh, if you lift something. So there's pressure that you put down on the abdomen with that effort that you've used, and it pushes on the bladder, and then leakage comes out. So that's called stress incontinence. Then there's something called urge incontinence or urge urinary incontinence. And that's when you get that strong feeling like gotta go, and you can't make it in time. And the urine starts to come out before you've gotten there. There's also something called mixed urinary incontinence. And that's when you could have both stress incontinence, where you leak when you cough, sneeze, or laugh, and you have leakage with urge incontinence, where you have an urge to go and you can't make it in time. So that's called mixed incontinence. So I would say people with Parkinson's disease tend to mostly present to me with urge incontinence. That is the most common because, as I mentioned earlier, urgency and frequency is a really, really common issue. And so those are kind of the main definitions. There's also something called functional incontinence. And that is if, say, you're on an off time and you can't move, you can't make it, and you leak. So that's a whole nother problem. And maybe we would use a combination of getting stronger with your pelvic muscle to hold back an urge to give you more time to then move and be able to get up out of bed and things like that. So a lot of times I do work a lot with people on transfers and other types of exercise. As you know, that's my other specialty, in getting moving better so that actually we can prevent some of those issues as well. So again, more of a full body or holistic approach to treating the incontinence, not just saying, oh, this is only a pelvic problem. Maybe this is a larger problem that we need to look at.
That was perfect. I think I've talked to people in support groups before, and they're like, oh no, I don't have incontinence. I feel like I have to go right away and it's too late. And it's like, well, no, that is part of incontinence once in a while.
Yeah.
So I think that was a great overview of what the different steps of that are. I'm going to go backwards a little bit. You mentioned biofeedback, that you do that. There may be a few people going, well, what is biofeedback? Can you maybe touch on that a little bit and how you would use that in some of these situations as well?
Absolutely. So it's a computerized kind of technology to get a digital output that you and I can both see visually what's actually happening with the muscle. So it's a way to retrain a process in our body that we might not be able to feel without some sort of visual feedback. And so what I use in the clinic typically they actually are internal sensors, and I don't want you to be afraid of what that is. They're small and very manageable, and there's a vaginal one for females, and then there's an anorectal one for males, and also for females if I'm working on bowel issues. Okay, so this little sensor gets placed inside. It's very private in the treatment session. You're covered up. I place it very briefly, and then we utilize the biofeedback. You're covered during that, and it's a private type treatment. So we utilize the feedback that we get from the muscle on the screen, and I try to help you train how to use the muscle in a more coordinated manner, and work on, like I mentioned before, determining, is this a strength issue? Is this a relaxation issue? What actually is going on? So we use that feedback to help optimize and individualize the home program. So when we can get that feedback, then I know that we're doing it correctly. So a lot of people say, I don't know if I'm doing it right. I don't know if I'm doing the exercise correctly. And this really helps give us this biological feedback of what's actually happening with the body so we can train that. Then what's great about it is session to session, we can compare. We can see, are we recruiting the muscle better? Is there an improvement in your ability to relax? What's actually happening? So it's really, really beneficial. And again, very individualized, because not everyone has the exact same problem with their muscle. So we have to individualize that.
Thank you. I think that's a great overview of what that is, and probably explains a few questions people might have. So you're unique. You're an occupational therapist who's also specializes in pelvic floor dysfunction. If I'm a Parkinson's patient and I'm experiencing some of the issues we've talked to, I probably shouldn't come to my occupational therapist. I probably should start with my provider on this, correct?
Yeah, so what would be best is if you mention these symptoms to your doctor and then get a prescription or a referral basically to a specialist. So there are a number of specialists throughout the Milwaukee area and throughout other areas that the WPA covers that have certifications or have specialties in this area. So I just want to note too, Jeremy, that not every pelvic rehabilitation practitioner per se, when we use that general term, has these certifications. So it's something that you can pursue. You need extra education in order to do that, and you have to take some board exams outside of your regular licensure. But not everyone that specializes in that actually goes for the full certification. So as long as they have the education backing them, there are other individuals that may just have a PT or an OT behind their name that also do specialize in this. There's a really great network, at least around this area that I'm very familiar with, of different locations where you can obtain these services. So having a referral is best though, because then you can get the process started right away to get an evaluation of actually what's going on with you.
Well, in getting the referral, I think it's always good to talk to your medical practitioner so that he or she is fully aware of everything that's going on that's related to your Parkinson's, not just some of the more specific cardinal symptoms that we're thinking of.
Exactly. And especially in that regard too, is you may need another medical specialist involved too, like a urologist, a gastroenterologist. So someone to see you for specifically for your bladder or your bowel, because it could be more complicated than just the muscle. That's my specialty, but we always want to make sure we rule out any sort of medical piece of this, that there's nothing else going on related to that.
Well, I appreciate it, because I think everything you've talked about so far, you've talked about how the urinary issues, the bowel issues, and the sexual dysfunction issues are all probably a part of your Parkinson's disease. And I think the reason some people don't bring this up with their movement disorder specialists is they weren't aware that it was part of the Parkinson's disease. I think you've given a great overview of how it all connects.
Mm-hmm.
So with that, anything I haven't touched on that you're like, this comes up a lot, people should really be aware of this, or here's the right question to ask when you're really wondering if this is Parkinson's related or not?
So I think that as long as you feel you don't have an infection or other like deeper things going on in the gut and things like that that you haven't gotten resolved, most likely it is like a non-motor symptom, we would call it, of Parkinson's disease, right? So again, like I mentioned before, Jeremy, there could be other medical things going on. We always want to make sure that that's not the case. But I think you really put it really well, that these symptoms are really common in people with Parkinson's disease. They're not as much talked about. When you go to see the doctor, he may have 15 to maybe 30 minutes with you, hopefully, which is great if they do. And sometimes at your initial appointment, longer than that, but your follow-ups might be a little shorter. And so those symptoms may not be top of mind for them to ask. And if you bring them forward, then the discussion can happen more in depth. I think that the attention might be more paid to the motor symptoms because the medication adjustments and things that have to be done in the more immediacy. And that sometimes people just like live with these problems. They live with their, oh, I just have to live with it, or I just wear a pad, or I just have to try to plan this bowel movement around everything. And Or, you know, it's just how it is. I'm getting older. We don't have the same relationship we did before in regards to our sexual life and things like that. But there may be something more, like you said, really intertwined in the disease that I can help to facilitate, and people like me in this field can help to facilitate and improve quality of life. It can really make a big difference in your life. So just keeping that in mind. And I also in the clinic get much more time than the neurologist would have. So I get anywhere from 45 to 60 minutes with individuals that I work with. And so and sometimes even longer depending on, you know, the availability of the day. So we can really spend some good amount of time discussing it and really analyzing it and figuring out the best solutions.
I think you just hit it on the head. It's quality of life. You shouldn't have to live with this. There are things that can be done, whether through exercise, medication, or other treatments. There's a lot of options to explore. Don't just accept it. There's a lot you can do, and there's great resources and professionals such as yourself. So, well, we're going to wrap up, Erica. I'm going to thank you for your time today and providing information on resources on pelvic floor disorders. While we are all practicing social distancing, please check in with the Wisconsin Parkinson's Association regularly. We are updating our website and Facebook page almost daily with exercise classes, educational videos such as this one, and a number of other resources for you to stay safer at home. Please email us at mail@wiparkinson.org with future topics you would like to see us covered by our local experts such as Erica. Again, thank you, Erica, for being our guest today, and thanks to you for joining us. Take care, be well.